Hello, everyone. Welcome to the fourth International Conference on Modern Medicine and Global Health 2026. I'm Alan Wang. I'm from the University of Auckland, associate professor. Today, it's my pleasure to share with you our recent research about bridging medical imaging and also artificial intelligence for personalized neural rehabilitation. So in today's presentation, I think the major context will include the following aspects. The first is intelligent neuroimaging data quantification, followed by the recent applications in personalized neurorehabilitation, followed by the discussion and the conclusion. First, let's look at the neuroimaging quantification. I think neural imaging quantification is very important before we can perform the further prediction or diagnosis or prognosis. So the quantification of neural imaging data can be classified into the quantification of lesion and the quantification of normal brain structures. So here in this slide, I share with you the traditional pipeline to quantify some lesion, for example, the infarct detection. So in this pipeline, we load the DWI data, diffusion weighted imaging data. After loading the data, we can apply the brain image mask so that we can quantify the analysis within the brain regions. By applying some thresholding algorithm utilizing mean intensity calculation, we can further perform the mathematical operation, for example, dilation and erosion to fill the hold. Then the marker images could be generated. Furthermore, we can continue to apply the morphological reconstruction, and by performing the calculating the difference between the original image and the morphological reconstructed image. We can calculate the difference image, and based on the difference image, we further perform the thresholding. And after that, we can reliably extract the infarct. So you can see there are a series of steps involved in the infarct quantification pipeline. And the advantage of this kind of pipeline is that it's not required to have a large number of sample size to train the algorithm. So this is a kind of a rule-based quantification. So the sample size required for this kind of rule-based quantification is very limited. This is the advantage. And the applications for the rule-based quantification is normally utilized to quantify the large lesions. So this is very efficient. So for the other methodologies, in comparison with the traditional neuroimaging quantification, that is the deep learning-based algorithm. So we have been working on the deep learning-based algorithm for quantifying brain lesions uh, in different areas. So here, this slide introduced the microbleeds quantification from the diffusion weighted imaging data. So the input data is DWI images. So we first perform some algorithm, including the intensity thresholding and RF retrieval. So the purpose is to identify some candidate small regions which could be the microbleeds. Then we perform some feature extraction among the candidates regions. So we further apply support vector machine to classify this kind of small patches into real microbleeds or not. So this pipeline integrates the deep learning-based region of interest detection as well as the machine learning based classification based to identify the final microbleeds. So this integrated pipeline achieved a relatively high sensitivity for the microbleed detection, which is about 90%. We know that the microbleeds from imaging data, especially for DMR images, the quantification, if we utilize the manual method, it can be very time consuming. And uh, so the deep learning based algorithm demonstrates a strong advantage in this area. So I introduced the deep learning based quantification algorithm. We know that it requires a larger sample size for deep learning algorithm. Nowadays, it's very common that we need to combine the data from multi-centers so that to increase the sample size. Then there is one problem. The data set, for the MRI data acquired from one center using, for example, scanner 1, the image appearance could be quite different from the MRI data from scanner 2. The reason is that MRI images it's different from the CT images. CT images contain the hot field values, which are really comparable across different CT images. But for the MRI data, the intensity values are relative values, means that the image appearance could be quite different from one scanner to the other scanner. So how to address this kind of scanner-related bias for the imaging data? So we propose the harmonization algorithm. So this is to reduce the scanner related bias for the imaging data. So the harmonization algorithm utilizing machine learning and deep learning algorithm, we can calibrate the imaging MR data so that the image appearance are very similar to each other among all the combined MR data across different size or different scanners, as shown in this slide. If you want to know a little bit more about the harmonization and the algorithm, there is a recent review paper about the harmonization algorithm. After that, we can perform further advanced modality analysis. For example, we can quantify the, we can perform the fiber tract extraction for using the diffusion tensor imaging data, and then we can further project the fiber tract to calculate the cortex region. This kind of cortex region could be utilized for for example, for the TMS, transcranial magnetic stimulation, there could be a target region. Normally, we require functional MR data, but now we can utilize diffusion tensor imaging, utilizing the fiber extension algorithm to identify the personalized target regions. Well, this is our another project which is utilizing multimodal, so integrated multimodal for MTBI quantification. This is a longitudinal MRI data. So we find substantial differences in the mean diffusivity and the axial diffusivity from diffusion tensor imaging between the rugby players and the controls. So this kind of imaging differences actually demonstrate the correlation with some symptoms related to the rugby. Oh, for regarding the brain neuroimaging data analysis, there is the traditional deep learning based algorithm. There are also other types of algorithm demonstrate strong advantage of computational relatively lower computational complexity. For example, the spiking neural network. So in this slide, I would like to share with you the brain-inspired spatial temporal associative memories for neuroimaging data classifications. So the brain actually functions as a spatial temporal associative memory inspired by our human brain. The brain-inspired spatial temporal associative memory was proposed before that utilized the new cube spiking neural network framework. So in this slide, the pilot study opens the field for the development of the classification system on other neuroimaging data, for example, longitudinal MRI data, trained on the complete but record even partial data. It still demonstrates advantage for analyzing the longitudinal neuroimaging data or the spatial temporal imaging data. So the message I want to deliver is that a spiking neural network can be very efficient in neuroimaging data quantifications. For the neuroimaging data, after quantification of the lesions, we need to incorporate the prior knowledge. How to incorporate the prior knowledge? One efficient way is to uh, embed the brain atlases. So this kind of brain atlases is very helpful for us to quantify the impact of for example, the lesions, or to quantify the abnormal changes. We know where is the changes, then we know, or we can apply the atlas and calculate the overlapping of the changes or the lesion with the atlas. Then we can further quantify the potential impact. Again, the advantage of this kind of atlas-based algorithm is that the sample size can be very small. I think this is very important. So here is the illustration of one atlas called aspect atlas. So normally aspect is used for CT quantification. So here we developed the MR-based atlas. Again, can quantify the impact of the stroke lesion or other lesions on the brain. So we developed other atlases, for example, the hybrid atlas. The hybrid means that it contains both the functional cortex brain regions, but also the structural white matter fiber bundles. So we combine them together, which is very comprehensive. We call this a hybrid atlas. It can be utilized for example, for the motor region or motor associated white matter tracks to quantify the impact of the lesions or other abnormalities. Our another very successful brain atlas is I want to share with you is the movement-specific structural and functional brain atlases, which is more comprehensive and recently published in Neuroimage. We developed the two atlases. One is called SSCA, the other is SMAA. So one is the white matter atlas, the other is the cortex atlas. In comparison with the existing whole brain atlas or functional based atlases, our movement specific structure and functional brain atlases demonstrate strong advantage in predicting stroke outcomes with in comparison with the existing one. So the atlas-based lesion loads relate to motor outcomes, but offer the limited predictive boost over baseline clinical scores. So we can see that the movement-specific atlases are more specific and more useful for predicting post-stroke outcomes, especially for the upper limb or lower limb function predictions. After that, because I mentioned several times the multimodal neuroimaging data, I want to share with you a little bit about the visualization. For example, from the left side, we can see the lesion. On the right side, we can see the vessel. So by utilizing the integrated visualization, we can combine the two modalities. For example, from the vessel image, we can incorporate the lesions, which is invisible if we don't apply the computational technology. Now we can put them together so the junior clinicians can visualize the lesion as well as the vascular structure in the same screen. They can rotate, zoom in and zoom out so that the relationship between the lesion and vascular structure can be clearly displayed. Other advanced neuroimaging quantification algorithm could be the synthetic imaging data generation. For example, we can generate MRI from CT utilizing deep learning algorithm. We try different algorithm and demonstrate the feasibility because sometimes the MRI data is not available, but MRI is very strong, very powerful to show the soft tissue for the gray matter and the white matter. We can then generate the MRI from the CT data. Or regarding to the registration from the personalized space to the standard brain template atlas, for us to deliver personalized stimulation, we need to rely on very reliable registration. But sometimes, for example, for the stroke patient, there could be a very large infarct, a very large hemorrhage. This kind of large lesion can affect the registration accuracy. So we propose an algorithm to perform the imprinting, so we can restore the lesion regions with the relatively computerized, computer-generated pseudo appearance, which is very similar to the normal tissue. After applying this kind of imprinting technique, we demonstrate that the registration accuracy can be significantly improved. So if we want to deliver a personalized, accurate target for the neuromodulation, we can rely on this kind of robust registration technique. Another trend is to integrating language into medical visual recognition and reasoning. This is our recent paper in medical image analysis. We demonstrate we give a very nice summary for the existing algorithm and point out the future direction, which is very potential. And also the simulation. Simulation, for example, the computational fluid dynamics simulation to simulate the risk of the aneurysm, for example, the rupture of the aneurysm. Regarding the stimulation, it's very common to apply the single coil transcranial magnetic stimulation TMS, but we propose because the single TMS can be relying on the operator, the experience. So we propose to deliver multi TMS coils for stimulation. So this is potentially can be very powerful because multiple regions can be stimulated, and also we can trigger some specific coils, TMS coils for implementing the personalized stimulation. This is our simulation results, demonstrate the feasibility and also the proper selection of the parameters to enable the robust multi-target magnetic brain stimulation. For the traditional TMS single coil or TMS stimulation, I mentioned the brain atlas and also mentioned the personalized neuroimaging data quantifications, including segmentation and the registration. All these kind of techniques can be combined together to deliver the personalized neuromodulation, neurorehabilitation. For example, we can know the target from the personalized MRI data, then we can perform the registration between the individual or personalized MRI with the brain template and atlas. And within the atlas, we can obtain enough prior knowledge about the location we want to target and also the functional region that we want to know for this personalized patient. So the tracking system can real-time track the TMS coil and also can real-time demonstrate the target within the brain. So this is the beauty of the image, personalized image-based planning and also navigation for TMS. For the structural and the functional MRI data, we propose that sometimes we want to predict the motor outcomes The traditional predictor algorithm may rely on the TMS. So we investigated that we can analyze the neuroimaging data and quantify the neuroimaging data. Based on the quantification of the personalized neuroimaging data, we still can predict the motor outcome for the stroke patient without relying on the TMS stimulation. And this approach is demonstrated the feasibility and published in Neuroimage Clinical. And for the prediction, now we are working on the prediction of the long-term symptoms based on the routine imaging data. It could be the CT or MRI, or even the advanced MR modalities. That we want to predict actually the different kind of scores, for example, motor function, language, visual spatial attention, visual spatial memory, corporal memory, etc. Finally, I want to share a little bit about the personalized rehabilitation utilizing augmented reality. We have developed augmented reality-based applications for rehabilitating patients with spatial neglect. And by integrating AR, artificial augmented reality, and also the artificial intelligence technology, and even the large language models to enhance the rehabilitation experience and outcomes for spatial neglect patients. Yeah, this is the brief introduction of what we have done in this area. Uh, I think it's very important to understand the brain changes um, for a specific patient, so then we can be able to deliver the personalized rehabilitation. Then for the brain changes, it could be the structure, it could be the function, it could be the connective dependence. So all this kind of information can inform the mechanism of the recovery across the different neurological conditions. So it's important to understand the brain changes by applying the uh, intelligent neuroimaging quantification. For the advanced analysis of neuroimaging data, we can utilize machine learning or traditional image processing algorithm, network analysis, and multimodal integration. All these technologies should be combined together to enable the prediction of the recovery trajectories. For the biomarkers, I think is very important and also very feasible, including the lesion characteristics, again, the connectivity, the profiles, clinical information, functional activation patterns. All these can also support the personalized prognosis. For the clinical applications, I think several areas could be covered, including early outcome prediction, tailored therapy or intervention, selection, and monitoring the rehabilitation progress. The conclusion of today's presentation is that the clinical translation is feasible, but we need to ensure that the AI models are interpretable and trustworthy and integrated into the real-world clinical flow. The future innovation, including the AR, VR, digital twins, and adaptive feedback systems, should be developed for the next generation rehabilitation. Of course, collaboration is very important and the key actually for success. The interdisciplinary partnerships between the clinician, the engineer, the researchers, and the patients is very important. So involving the patient, we can call this co-created pattern. The vision, I think, in the future where the imaging and AI can work together and to deliver the precision, efficiency, and equity in neurorehabilitation. So this is the trend. So the final message, take-home message is that bridging imaging and AI paves the way toward a smarter and more personalized care for neurological disorders. Finally, I want to thank our collaborators and funding agencies. Thank you.